Hey guys, welcome back. The topic that we're going to study now is pancreatic neuroendocrine tumors. And the first one on the agenda would be a incidence-based data where it's going to talk about which is the commonest functioning pancreatic neuroendocrine tumor versus a non-functioning one. The non-functioning one will only produce a mass effect and maybe a bit of metastasis also. So the most common functioning one is well known of Whipple's triad per se. That's going to be insulinoma. But when he talks about non-functioning one, this would be producing pancreatic polypeptide. So the answer here would be given as PPoma. Though the non-functioning one can even be producing chromogranin A. It could be even producing chromogranin B. And where have you read about chromogranin A and B? You have read about them in pathology, even with respect to carcinoid tumor. So yes, carcinoid tumor also has chromogranin A and B, but PPoma can also express them. The bottom line is, when I say the word non-functioning, this will not have any hormone related effects. All it will produce a mass effect. And as I said, lots of time the diagnosis is made late. So metastasis to the liver can be present. The standard presentation for a non-functioning tumor of the pancreas would be presence of abdominal pain, and then it could be jaundice because it's anyway close to the biliary pathway, and there could be substantial weight loss and cachexia developing in the patient. So you might think patient is having a pancreatic adenocarcinoma, and it was later on found that this is producing pancreatic polypeptide or maybe chromogranin A or B. But as such, hormone related effects will not be present, unlike an insulinoma where the standard presentation will be that of hypoglycemia. So while I'm writing causes of hypoglycemia before you and then start talking about insulinoma more in detail, my question to you guys is, what is the cutoff for hypoglycemia per se from a diabetic's perspective? I mean, when would you tell a diabetic that, okay, if blood sugar is less than this much, you need to take something sweet? Well, if you have checked out the blood reports per se, you will always notice the normal blood sugar is always described as something in the range of about 70 to 100. So if the blood sugar becomes less than 70, that would be a alert level for diabetics. I'll talk about levels of hypoglycemia subsequently, but this is an alert level. Why this is so is because when the blood sugar tends to go less than 70, this is the level at which insulin production stops. This is itself a question. Insulin production stops at blood sugar values of approximately 70. And now, if you have not had your breakfast and you go for your Viva, you would be operating on counter-regulatory hormones. One of the counter-regulatory hormones would be glucagon, then would be cortisol, catecholamines. Catecholamines definitely can contribute to even palpitations and tremors developing in a patient apart from lack of concentration. So there are 4 counter-regulatory hormones that I have elaborated here, which would be present in every patient for hypoglycemia. And this is to be remembered anyway for, as I'll say, 2 cutoffs for hypoglycemia. If I simply say what is the alert value for hypoglycemia with respect to a diabetes mellitus patient, the answer is less than 70 because the person should start taking something sweet. But as the blood sugar will fall, the counter-regulatory hormones will increase. So what is the cutoff that is to be taken for hypoglycemia per se? When I say neuroglycopenia will set in, the neuroglycopenia manifestations usually start appearing around about 54. Level 1 of hypoglycemia is when the blood sugar of the patient is between 55 to 70 milligram percent. That is when counter-regulatory hormones will be sufficient for operation of the patient. Like, let me say doctors tend to neglect their breakfast and they go for their Vivas, their ward duties. So if the blood sugar is between this range, you would still be able to operate. But once blood sugar starts going less than 55, or to be precise, less than 54, that is when a person's ability to perform will be substantially reduced. The person will start feeling sleepy and lethargic. So this is when neuroglycopenia is setting in. When I say level 3, they have not mentioned any cutoff. They have simply said that the person will at this point of time have a requirement of another person to help him. There would be requirement of assistance, because if blood sugar is something in the range of 40, this person cannot come to the hospital by himself. This diabetic, or let me say any other cause of hypoglycemia that I'll enumerate before you, this person will be lying in his bed. He's not opening his eyes since morning, or let me say now he has been sleeping for 24 hours, and the family members are worried that he's not an alcoholic, he doesn't take drugs, and he's sleeping a lot. So the family members had to literally carry him in the car and bring him to the casualty of a hospital, and you did maybe a capillary blood glucose, and the value was maybe 40 or even lesser than this. So requirement of assistance of another person would be when I would say the person would be having a level 3 hypoglycemia. And if intervention is not done, then guys, the neuroglycopenia component that I'm talking about can be so serious that it can even contribute to hypoglycemic seizures and can even contribute to coma in a patient. In pediatrics, we always read about hypoglycemia with respect to low birth weight babies and infant or diabetic mothers. So we are more, I would say, comfortable there, and the cutoffs are well defined. But for adults, it depends on, I would say, the resistance of an individual, because if somebody is habituated to not having a breakfast and he's habituated to operating on, I would say, catecholamines and the counter-regulatory hormones, then this person who's habituated for hypoglycemia might be able to handle it relatively better. But once the blood sugar starts falling beyond the values that I've highlighted, that is level 2 of hypoglycemia, once neuroglycopenia sets in, that's when the person would be lying in bed, eyes closed, and would be rather, I would say, very irritable if somebody tries to wake him up. The symptoms of hypoglycemia can contribute to a person being called as having a personality disorder. I mean, that irritable the person will be. So let's have a look at some of the important causes for hypoglycemia before we talk about insulinoma, which will be one of the causes. Hypoglycemia is encountered in patients of chronic kidney disease. Why? In chronic kidney disease, you see what's going to happen is that insulin will also not be excreted, because insulin is excreted by the kidney. I'm not talking about insulin that you're giving from outside to a diabetic patient. I'm saying, let me say somebody is having CKD due to medical disease. Even then, hypoglycemia can set in. Why? Because the endogenous insulin is excreted by the kidney. If insulin will not be excreted for a longer duration, it will be able to act for longer duration, contributing to hypoglycemia. Similarly, if a person is having severe liver disease, because liver is the store where a person would be having glycogen, and the glycogen stores would anyway be depleted. Then alcoholics. I mean, alcoholics anyway, because they would like to binge on alcohol and not eat food items, because all this guy says is, I need to fix my drink. So a guy who is so, I would say, addicted to alcohol that he all requires is alcohol for his survival and doesn't need anything else, they're prone to development of hypoglycemia. Then obviously in our country, especially with respect to pediatric domain, poor nutrition would come in. Or like you read also about, rural India, especially if there's a famine, there's floods, people starve to death, so hypoglycemia manifestations will occur. Then can be extra pancreatic tumors. Now when I describe these extra pancreatic tumors, it could be something like a leukemia. A leukemia will be having a tremendous increase in blood sugar requirement, because after all the cells have to multiply, so the metabolic requirements of the body will definitely be increased. Or suppose somebody is having aggressive sarcoma, even then the sugar values can be lesser, and then can be misused by a medical personnel. Like, let me say this guy is a doctor or a nurse, and he knows that insulin can cause hypoglycemia. So if a person is deliberately, I'm talking about the Munchausen syndrome component here, that if a person is abusing insulin or sulfonylureas, then there's a possibility that hypoglycemia will come in. So all these causes are definitely to be ruled out before you consider insulinoma in the list of your differential diagnosis. So whenever you are seeing a guy with low blood sugar, I'm going to run a LFT, I'm going to check out the KFT of the patient, I'm going to check out the dietary history of an individual, take care of the fact that he's not having cachexia. I want to say at this point of time that insulinoma is anyway a rare diagnosis, and patients of insulinoma will always be having a weight gain, whereas in other conditions that I've written before you, that's only a hint. I'm not saying that weight is going to be an absolute way to identify it, but most of the conditions you see CKD, CLD are catabolic processes, so weight loss will be present. But insulinoma, you would be having like a 20-30 kilogram weight gain in a patient. As far as management of hypoglycemia is concerned, the first step in management of any person having neuroglycopenia, you see, if blood sugar is around about 70, you can ask him to take some sweets. But if there's going to be neuroglycopenia in a patient, I will have to secure an IV line and give 25 to 50% dextrose in the patient. Question for you guys, a patient is having blood sugar of 40 in the casualty and he started having convulsions right before your eyes. If somebody is having convulsion, putting an IV cannula will definitely be difficult. Though you are trained for it, what I am saying is when a person is having a convulsion, the cannula might get counted also. So suppose an adult person is having a hypoglycemic seizure right before your eyes. You have documented that by capillary blood glucose, it was lesser and suddenly the patient started convulsing. You did not have time to give IV 25 to 50% dextrose, which is the norm. Then how would you stabilize the blood sugar of this patient? Just a general question before we move ahead. You can be using glucagon injection. And if you do not have glucagon injection, because glucagon injection will anyway contribute to glycogenolysis and it will raise the blood sugar values. So in patients of hypoglycemia, if IV line cannot be obtained, you definitely can be giving glucagon. And if you don't have glucagon, you can even give epinephrine in low dosage, right? Instead of 1 milligram, let me say 0.5 milligram, you can give it subcut, and even that will cause catecholamine release. Though the epinephrine part that I'm saying is totally off label, it is glucagon which is to be answered in the exam. But I'm saying in a worst case scenario, you're not able to secure an IV line, giving anticonvulsants will obviously not make sense for this person. So what you can do in this patient is definitely give glucagon, or as I said, off label, I mean epinephrine can also be used. Now let's focus on the aspects related to insulinoma. The classical information that you read for this topic will always revolve around Whipple's triad. So let's look at the three components of Whipple's triad initially. The first and the foremost would be symptoms of hypoglycemia, which will be causing this person to be labeled as having a very moody person, or as if people will say that he's a very strange kind of personality. He gets angry very soon. He starts crying at let me say drop of a hat if somebody says something to him, or gets angry very soon. So symptoms of hypoglycemia and sympathomimetic stimulation would definitely be present in this patient. When you are going to check out the blood sugar by capillary blood glucose or a regular blood sugar monitoring, or even if you do a random blood sugar in this patient, the blood sugar will definitely be low. So here I'm putting a value of, it's usually a range given in books around about 40 to 54 milligram percent, which would be setting up level 2 of hypoglycemia. And then there would be immediate relief the moment you in this person will secure an IV line, because most of the time if it is neuroglycopenia and the person becomes drowsy, that's difficult to wake him up. So there would be immediate relief of symptoms and the person will open his eyes and would start talking normally, though there will be a rebound hypoglycemia subsequently developing, but immediate relief of symptoms would be seen in case you are able to give IV glucose to this patient. And it's not that only IV glucose, if the person is I would say capable of taking care of himself, even oral sugar administration or something sweet can definitely help this person recover. Now when we study about insulinoma, in the MCQ he will try to mix up the information of insulinoma with glucagonoma. You see, glucagonoma, majority cases are malignant. They have already metastasized to the liver. But when it comes to incidence of malignancy, in insulinoma, majority of these are benign. It is about 5 to 15% which are malignant. I repeat that statement once again, so I'll just use an alternative pen to write it. CF means contrast from glucagonoma, because this kind of epidemiological information can be mixed in the question. Majority of glucagonomas are malignant, insulinomas are predominantly benign. The size of glucagonoma usually at the time of diagnosis can be in the range of about 5 centimeter. Whereas when it comes to insulinoma, they are majority small, and because they are small, therefore they will be difficult to pick up with the CT or MRI, which explains the fact that why do we use endoscopic ultrasound, or we might be even using somatostatin receptor scans for identification of neuroendocrine tumors. I will tell you the how to answer or what to answer primarily for insulinoma when it comes to the imaging modality of choice. But one thing is very, very clear, that don't answer a CT or a MRI right away, because if it is early presentation and the tumor is, let me say, 0.5 millimeter, CT or MRI will draw a blank. In contrast, glucagonoma, because majority of them are having hyperglycemia and are having a large tumor, CT, MRI will definitely work. So what is the imaging modality of choice that will come, and I'll describe it subsequently in our discussion with respect to insulinoma. I mentioned the size would be about 2 centimeter, and then they also talk about the location. When it comes to a glucagonoma, majority of glucagonomas would be located in the tail of the pancreas. Whereas when it comes to an insulinoma, it will be distributed equally between all the parts, that is the head and the neck and the tail of the pancreas. So I'll just jot that down, so that 33% of these tumors, or 33.3% of tumors in the head, 33.3% in the neck, and then the remaining part could be found in the tail. So it could be anywhere around the pancreas, where the glucagonomas are concentrated mainly in the tail. Now we will talk about two more terms before we talk about how the patient will present. One of the terms is called as insulinomatosis, and the second one is read in pediatrics, that is nesidioblastosis. So let me just clear up these terms before we talk about the clinical domain and the workup for this patient and what are the critical samples which are to be sent. Insulinomatosis means micro/macro adenomas in the pancreas, Why that is surprising is because traditionally when you read endocrinology, you read about microadenoma in the pituitary, you read about macroadenoma in the pituitary. Like if a macroadenoma that's more than 10 millimeter size in the pituitary, it can contribute to pressure on the optic chiasm, and you read about bitemporal hemianopia or visual deficits in a patient. So why I have highlighted this term is simply because you read about micro and macroadenomas in the pituitary, but here we are talking about macroadenomas in the pancreas, and they can be distributed all over the pancreas, and therefore they could be producing extra amount of insulin and can contribute to hypoglycemia as well, though the incidence of insulinomatosis is even lesser than that of insulinoma. But this is one of the differentials definitely be kept in mind. And then I mentioned from the pediatric domain the term nesidioblastosis. Nesidioblastosis basically means that this child is having a beta cell hyperplasia, and because of this hyperplasia there will be more production of insulin. Well, if you're having extra insulin in the body of a child, that will contribute to hypoglycemia. So you thought that this baby is having hypoglycemia because the mother was having gestational diabetes mellitus, or she was having pre-existing diabetes, and therefore you decided to give glucose infusions to the child, but still the sugar is not coming up. That sugar is not coming up not because he's having maternal hyperinsulinism contributing to fetal hyperinsulinism, but rather there's a condition in the pancreas of this baby which is contributing to this persistent hypoglycemia. So these are two special terms which definitely should be remembered: insulinomatosis and nesidioblastosis, which explain hypoglycemia if insulinoma is ruled out. Now let's look at why patients would come to me. One of the reasons would be that the family members will say, initially he is presented with hypoglycemia, so he may not be in a position to talk, but family members will say that this guy eats a lot. Because of the hypoglycemia component, frequent eating and substantial weight gain will be present in patients of insulinoma. And then symptoms of hypoglycemia will also be described, like family members saying that he gets angry very soon, rage attacks, or he tends to start crying if somebody says a minimal aspect. I mean, I'll put it like this: hypoglycemia makes you angry very fast, hypoglycemia makes you tearful very fast. So emotional ability, he will not be able to focus on job here, concentration span. So family members are saying that when we ask him to do any particular task, he is more interested in eating. Sympathomimetic symptoms will also be noticed subsequently. There would be fine tremors. The person will complain of palpitations. Most of the time, the diagnosis of this disease might take even months to years, because initially the symptoms might look very non-specific, but subsequently, because this person is having documentation, laboratory-wise documentation of persistent hypoglycemia, that is when the critical sample would be sent and you will be able to identify this condition. The age of presentation is usually 40 to 50 years of age, though has been documented earlier and even after this, and it can be associated with multiple endocrine neoplasia type 1. The topic of multiple endocrine neoplasia is discussed subsequently in the endocrinology section itself. What I'll do for this person will be run blood sugar values and double check whether those blood sugar values are fine. But then once I'm sure that there is no error on the part of the laboratory, I need to send a critical sample, and this critical sample that I need to send is with respect to a very particular terminology that you read. And this is one of the reasons why the question is asked in the exams for insulinoma, that what test will help in confirmation or diagnosis. This would be a 72-hour prolonged fasting test. First, I would like to clear the fact that it's not that I'm going to keep this hypoglycemic patient hungry for that long a period. It is simply that I will tell this person not to take anything, and I will be taking 4 hourly samples of these patients to document the hypoglycemia component as it will evolve from level 1 towards level 2. And I will also be checking out the values of C-peptide and a couple of other tests that I'll explain, by which I'll be able to pick up that the hypoglycemia of this particular patient is related to excessive insulin production. So let me now enumerate before you what are the tests that would be done on a 4 hourly basis to document insulinoma. The first test that I'll be doing in this individual for workup would be obviously blood glucose values, which usually will be documented to be in the range of about 40. It could be lesser than this also. All I'm saying is why value of 40 is because if any normal person like you and me is having such a severe hypoglycemia, then the insulin production will definitely stop and the radioimmunoassay will definitely be lesser. Studies have shown that if blood sugar is less than 40 or reaching about 40 in a normal person like you and me, then the insulin values will also start reducing and will be less than 6 micro units per ml. You don't need to remember the mathematical value, but the simple point I'm trying to say is insulin will decrease or stop, total production will stop, so values will decrease if the blood sugar tends to fall. But in this patient, the values will definitely be above this particular threshold that I have mentioned. So one, you have documented elevated insulin. Now to prove that this is endogenous insulin and not an exogenous insulin, you will be doing a C-peptide value in the patient as well. Because after all, if somebody is using exogenous insulin, then by feedback mechanism, C-peptide levels will reduce. But in this chart, the C-peptide values are elevated. This proves it is endogenous insulin. I will also be checking the values of proinsulin in this patient. You see, insulin as a molecule is composed of A chain, B chain and C peptide. So this inactive form of insulin will also be elevated. The fifth investigation is to be listened with care. What I'll be checking in this patient will be a insulin glucose ratio. Traditionally, we always read about insulin glucagon ratio, but in this case, what we are talking about is a insulin glucose ratio. And well, normal individual, this value is less than 0.3. My point is, you need to not remember the mathematical value, but just go by mathematics. If somebody is having an insulinoma, the numerator insulin values will anyway be increased. So this value will be increased. In MCQ it will be written increase. The mathematical value, whatever is the normal threshold, will be exceeded. The sixth test that I'll do in this patient will be to check out the value of ketone bodies. You see, whenever somebody is having insulinopenia, like in diabetic ketoacidosis, we have less insulin. Less insulin causes ketones to spike because there is burning of fat. But if there is opposite, if insulin is more, then the ketone bodies are lesser. I'll repeat the fact, when insulin is less, ketone bodies will rise. Opposite, right? Insulin and ketone have an inverse relation. When insulin is more, there would be less values of ketone bodies. So I will be checking for one that we routinely are able to estimate in the lab, that is beta hydroxybutyrate, and we'll be able to see that this person will be having a low value of plasma beta hydroxybutyrate. The subsequent test that I'm going to order for this person is to rule out factitious hypoglycemia due to abuse of sulfonylureas. You see, earlier I had told you that if a person is using insulin from outside, if it is exogenous insulin being abused by healthcare worker to produce hypoglycemia symptoms in himself, then C-peptide values will be lesser. But at the moment, I'm going to check out the urine of this patient. The urine screen will be for sulfonylureas. So factitious hypoglycemia has been ruled out in this person. Out of the 7 tests that I have marked out, at least 2 which are of high sensitivity and specificity are marked out in blue. That is blood glucose values and proinsulin values. Obviously, all of these tests are to be done, but these 2 tests, if documented, you have to think in terms of possibility of an insulinoma, and the testing will be repeated on a 4-hourly basis. Now remember my words, it is not that I'm gonna wait for 4 hours only and then draw a sample. Suppose I start the test at 0 hour and symptoms of hypoglycemia are occurring after 3 hours of fasting, I will draw the sample then and there only, because if I can document the hypoglycemia component of this patient and simultaneously document that insulin and proinsulin are elevated, 50% of the diagnosis is made. Why I said 50%? Because at the moment I've just documented the endocrine impact of the disease, or I would say the laboratory part of the disease, but the imaging is still to be done because we need to document that there is a source that is producing large amount of insulin. So let us now study regarding what is the imaging modality that will be useful for diagnosis of a insulinoma. Your answer in the exam for imaging modality of choice would be given as a endoscopic ultrasound. In surgery classes, you will also be taught regarding somatostatin scintigraphy or somatostatin receptor based tests. But the basic point is that SRI or somatostatin receptor based investigations, they will be able to localize all. In fact, this statement is important from the MCQ perspective, that it can localize all the pancreatic neuroendocrine tumors. No issues with that except insulinoma. Now, why I'm saying that is because insulinomas usually have no expression or minimal expression of somatostatin receptors. I'm just using a short form instead of writing the word somatostatin. SST receptors, there are 5 types of it from SST1 to SST5. So somatostatin receptors expression is low. on insulinoma. This is a line from Harrison that I'm quoting at the moment, and because these receptor levels are lower, therefore somatostatin scan will not be able to identify it. So instead of doing a SRI or somatostatin scintigraphy, we will be more comfortable answering endoscopic ultrasound. One more investigation that is useful for imaging of these patients and is to be remembered is a PET CT. Obviously, if I said plain CT scan, it would not make sense because any tumor less than 1.5 centimeter may not be picked up on a CT or a MRI, but PET CT, which will be using here gallium-68. Remember, not 18-fluorodeoxyglucose here, but PET CT gallium-68 will be able to localize the tumor. So these are imaging modalities which are to localize the tumor, and combination of the two, the testing that I mentioned initially and the imaging modality would help you in completing the diagnosis. Let us now focus on what will be the treatment for these patients. So the first and the foremost would be that I'll be telling this person of repeated hypoglycemic episodes, who's always very EG, always very moody, having mood swings, to take frequent small meals, which will make him feel relatively better as the blood sugar values will go towards 70 or higher. Then I'll be prescribing a drug to this patient, and I'll also break the bad news that there's a possibility that the tumor which is currently present in your pancreas is very small in size but could have metastasized to the liver. He's not going to take that kindly when you tell somebody it's a small tumor but has metastasized. But then, as I told you, 5 to 15% incidence of metastasis is very much there. I'll tell him I'm putting you on a medication at the moment that will reduce the production of insulin which is in excess by this tumor. So the drug that we also study in pharmacology is diazoxide, which is useful for management of hypertension. It would be affecting the potassium channels because you very well know potassium channels are related to the release of insulin. I said related to the release of insulin, and in this case the drug will be acting on these potassium channels. It will open them and therefore decrease, I said open them and decrease insulin release per se. So diazoxide is one of the drugs primarily used for management of these patients. Then is the role of octreotide. You very well know it is a somatostatin analog and is now available in long-acting format also, that is called as lanreotide. So even this inhibitory drug can be used, or this drug that is going to mimic the activity of an inhibitory hormone, somatostatin, can be used. But there's a problem. Studies have shown that in about 25 to 40% of cases, because octreotide anyway decreases growth hormone levels also. Remember, in acromegaly, or when you will scroll down and subsequently listen to my diseases of the anterior pituitary, you will see me talking about lanreotide for patients of acromegaly to shrink the pituitary tumor. Lanreotide also decreases growth hormone levels. Now the problem is, if I decrease the growth hormone levels in this patient, then sugar values will also reduce. The problem is sugar is already less in the body of these patients. So some patients are not able to tolerate this drug. When you start these patients on injections or lanreotide, patient will come back and say, sir, this drug is not suiting me. I mean, that's the word that most Indian patients will say, that this drug, I'm not comfortable with this drug. I have side effects with this drug. And he's right, because his pre-existing hypoglycemia may be worsened, but this will be seen in only 25 to 40% of the cases. So this drug will definitely be used, but this means the fact that in a multiple choice question, if you have to select between diazoxide versus octreotide, considering that 40% patients can be having this side effect of hypoglycemia, your first answer for the drug of choice for this condition would be diazoxide. In case the tumor is malignant, the approach will change diametrically, because then anyway there are hepatic mets present in the person. So sometimes, I mean, when you calculate the 5-year survival rate, if it turns out to be dismal, patient might even say, sir, I don't want to take treatment. But we as doctors will definitely tell him to seek medical treatment so that we can increase his lifespan. So one of the methods of managing these patients who are having a malignant insulinoma would be chemoimmobilization. Apart from this, even radio-labeled somatostatin can be given, and therefore the radioactivity component can contribute to destruction of this tumor which has metastasized to the liver. Other drugs which are mentioned in the textbook, though I would say you have to give more importance to diazoxide and octreotide for your answers in the MCQ, but still for the sake of completion, for malignant insulinomas, mTOR inhibitors have been used. What are the names here? Mammalian target or rapamycin inhibitor. So one of them is everolimus. Last time I spoke about everolimus was in cardiology for drug-eluting stents. Remember, in cardiology we talked about in chronic stable angina, drug-eluting stents are coated with everolimus. The same mTOR inhibitor is being used even in this patient, apart from rapamycin, though they have their own set of side effects. In malignant insulinomas anyway, the prognosis will be relatively bad, but almost in 80-85% cases, because it will be benign, so medical management will definitely be useful in these patients. I can also mention some baseline information from physiology for this particular topic here. Though you are very well aware of this, let us assume this to be the beta cell of pancreas, and it will be responsible for release of insulin. So beta cell of pancreas, one produces a hormone that is by the name of amylin that will regulate the stomach motility, and second, with help of potassium channels, it will be able to release insulin, which is released in inactive form, that is proinsulin. And along with this, obviously C peptide will be released, and that is a marker of natural insulin that I've highlighted. The reason why I'm saying this is because proinsulin or insulin molecule will be having a A chain and will be having a B chain, and will also be having a C chain that will be interlinking the two. That's the C peptide per se. This is responsible for linking, and this basic physiology I just wanted to say that A chain will be having 21 amino acids, B chain will be having 30 amino acids, and the C peptide, the link between the two, would be having 33 amino acids. Because they ask integrated questions nowadays, so there's a possibility that apart from talking about the frequent eating bouts and frequent crying bouts and frequent anger bouts of these patients, which are relieved by intake of sugar, he might even incorporate these aspects of insulin breakup with respect to amino acid sequences as well. So these are aspects that you should be aware with respect to insulinoma. And now I'll compare this with symptoms that are present in a patient of glucagonoma. For identification of glucagonoma, we can be using a mnemonic by the name of 3D for its features, like we read about 3Ds with respect to patients of niacin deficiency. The first and the foremost would be development of pre-diabetes mellitus in these patients, or I can say impaired glucose tolerance. That's primarily because the main hormone that is increased in these patients is glucagon, which will drive up the blood sugar values. The second D would be for diarrhea, and the third one will be for a dermatological manifestation. This is a very characteristic dermatological feature which is seen in these patients, though it can be found in other conditions that I'll enumerate before you, but the name is very characteristic for this, and it's one of the primary reasons why this topic is asked. The dermatological lesion present here is called as migratory necrolytic erythema. As the name suggests, migratory, so it could be developing at multiple sites. So let's look at how the lesions will develop and what are the sites they would be present. Initially, there would be simply a red rash, but then this would get converted into bulla. These bullas will then rupture to result in development of big multiple erosions at multiple sites. That's why the name is necrolytic. What is the location? Most of the time they could be present in the intertriginous areas. Apart from this, it can be present on the buttocks of the patient, or even around the lips of the patient. So periorofacial sites are this locations where this could be present. Just like you're aware of the fact that photodermatitis, that's the Castle's necklace that you see, is a dermatological feature of niacin deficiency. I've mentioned a special dermatological feature which is asked in the exam, though it can be seen even with blood cancers, and I'll enumerate towards the subsequent part of the discussion what are other conditions where you will read migratory necrolytic erythema, but this is one of the characteristic features that is seen in glucagonoma. Apart from this, weight loss will also be encountered, in contrast to insulinoma, where we were talking about a weight gain of a person. Epidemiological data with respect to the size and the location is what I have already enumerated. Just a quick repetition: 5 to 10 centimeter, usually at the time of diagnosis, so a CT or MRI will help you pick it up. Mainly the location will be at the tail of the pancreas. The third feature, which is again important from the exam perspective, would be that this tumor is mainly malignant, so mets would be present in the liver, and therefore in majority of cases, well, nothing much can be done. Let's look at the workup. A very striking, I would say, laboratory feature is present. That would be plasma glucagon values. I mean, you don't read about this test anywhere else. So when you check out the plasma glucagon values, this would be in 3 digits. I mean, the values of hormone are increased to almost 10x of normal. That would be 1000 picogram per ml. For imaging in this case, yes, if it was smaller, I could have done for or gone for a somatostatin receptor imaging. But in majority of cases, when the case presents to us, it's really big in size. So MRI or CT abdomen will suffice, and it will also help us in determining that there are metastases to the liver of the patient. In fact, the incidence of metastasis to the liver in glucagonoma at the time of diagnosis is as high as 80%. So what is that we can do for these patients? Well, nothing much. It is just a debulking surgery can be done. The meds to the liver will definitely be handled. That will require an extensive team of oncologists and surgeons to work on this patient. And apart from this, even radio-labeled somatostatin can be used. And so we can just make it radio-labeled or loaded with radioactive pharmaceutical. And therefore, once it is taken up by the tumor, the radioactivity component will cause destruction of the tumor. The main reason why this topic is asked is mainly for the skin lesion, and you can very well see that the examiner will have a lot of opportunity at this point of time to talk about dermatological manifestations that can be seen in diabetes mellitus. Though I have spoken about diabetic dermopathy in diabetes mellitus also, I'm just using this opportunity once again to talk regarding necrobiosis lipidoica diabeticorum. The image-based question of this is described even in rapid revision, but at the moment we are focusing on theory, so the lesion will be on the shin. It's gonna be again reddish in color, but it will be definitely having a central clearing present. And he will obviously describe that this is a diabetic patient, and the lesions will be grossly red, inflamed, and will be totally different from any fungal infections, which again could be having a central clearing. Then you could be given a image-based question where a diabetic patient could be having hyperpigmentation. A hyperpigmentation will be present in let me say the groin of the patient, or in the axilla of the patient, or even the backside of the neck of the patient. So acanthosis nigricans. You all have read about acanthosis nigricans with PCOD and diabetes mellitus, but they can even be seen with malignancies like carcinoma pancreas, like Steve Jobs, the richest man previously with respect to Apple. Apple is anyway one of the richest companies in the world. So Steve Jobs actually had pancreatic cancer. He was a white guy, and he started developing this hyperpigmentation with respect to multiple sites in his body, for which when he went to his physician immediately ordered a CT abdomen, and that picked up a large carcinoma pancreas, which subsequently could not be managed, and he expired subsequently. Then when it comes to migratory necrolytic erythema, which I just explained for glucagonoma, can also be seen with hematological malignancies. So they will ask you which ones, and your answer would be given as myeloproliferative disorders that would range from essential thrombocytosis to polycythemia vera to chronic myeloid leukemia. Then even malnutrition, we have migratory necrolytic erythema. The third important condition where this is encountered is short bowel syndrome. So you are now aware of 4 conditions, 3 on the board at the moment, apart from glucagonoma, where migratory necrolytic erythema would be present. And in fact, if you just focus on the 3 Ds that I mentioned initially for this topic, you would be able to remember the features along with weight loss, in contrast to insulinoma that has a weight gain. Let's compare these features with another tumor now that is called as somatostatinoma. Somatostatin is an inhibitory hormone. It will inhibit the insulin production, and as a result of it, the blood sugar values will start rising, and again diabetes mellitus or impaired glucose tolerance could be present in the patient. Because they love to ask integrated, so a bit of physiology here. This is a tetradecapeptide. The sites where somatostatin can be found in the body is one in CNS, and second could be in the GI tract. And now let's look at the manifestations that would be seen here. I had requested you to remember 3 Ds for features of glucagonoma. Now I'm teaching you 2 Ds and a G. So it was triple D, now it is DDG for remembering features of somatostatinoma syndrome. In fact, this is ultra rare. Harrison says that there were even some studies which doubted the existence of somatostatinoma syndrome, but subsequently some case series have revealed that this rare syndrome is present. So we are reading a disease at the moment which the textbook itself says the existence of this has been doubted. The first point that is to be remembered from the mnemonic perspective is because somatostatin will inhibit the insulin release, therefore the blood sugar of this patient will definitely rise. So either of the two, either it could be pre-diabetes or even diabetes like values could be present. The next thing is because it is inhibitory hormone of the GI tract, so it will inhibit the release of pancreatic amylase. Now, pancreatic amylase helps in absorption of sugar. So if sugar is not going to be absorbed, it's going to contribute to osmotic diarrhea. So that's why the second D came up, that is diarrhea. And apart from this, I can say even pancreatic lipase release will also be inhibited. As a result of it, there would be a development of steatorrhea. So fat soluble vitamin deficiency, greasy, bulky stools, foul smelling stools would be a description given. The third manifestation can be remembered by the fact that this inhibitory hormone of the gut will inhibit the release of cholecystokinin, which is responsible for the gallbladder motility. Now, because the gallbladder motility is hampered, therefore there would be a gallbladder sludge, and therefore this sludge can contribute to stasis and can contribute to development of gallstones in these patients as well. So if you just focus on the three alphabets here, DDG, that is diabetes mellitus, glucagon, then is diarrhea because of inhibition of pancreatic amylase along with steatorrhea, and gallbladder disease in these patients, you would be able to remember features of somatostatinoma syndrome. The fourth feature can be remembered simply by the fact that this can also inhibit the release of chloride. So hypochlorhydria will also be present. And why that is important for you to remember is because after this, the topic that I'll be teaching you will be VIPoma, Werner-Morrison syndrome. So even in VIPoma, you read about hypochlorhydria. So just remember, hypochlorhydria is not only present in VIPoma, but it is also encountered in somatostatinoma. The primary top three features is what I've already explained to you. And because the disease is rare anyway, somatostatin levels shooting through the roof, 10x of normal, are to be documented along with the imaging modality that can be somatostatin receptor imaging. Let's now compare this with the VIPoma. Now, VIP is a 28 amino acid peptide which is going to be produced from the F cells of the pancreas. Like you are aware, alpha cells produce glucagon, and then beta cells produce insulin, delta cells produce somatostatin. It is the F cells that would be producing VIP. This tumor is mainly located in the pancreas, but sometimes can be having extra pancreatic sites also being asked. The surprising answer for this extra pancreatic site would be this VIPoma, or excess of VIP can be also with respect to carcinoid tumor. And then in pediatrics, we have a tumor by the name of ganglioneuroma. So previously I was talking about tumors which are originating primarily in the pancreas, neuroendocrine, but here I have spoken regarding what they can ask you about is extra pancreatic sites as well. VIPoma is found in the GI tract, but is also found in the CNS. So just like I said for somatostatin, both CNS and GIT, same here for VIPoma also. And this VIPoma can also contribute to development of vasodilation, because that's one of the physiological effects if it is released from central nervous system apart from release from the intestine. And because of this vasodilation component, one very characteristic feature that can be written in the MCQ is flushing episodes. The first time you read about flushing episodes is carcinoid tumor or carcinoid syndrome, but now I told you one more reason where flushing episodes could be described in the question. Let's look at why the clinical presentation or how it will be given to you. The GI manifestation will be that of watery diarrhea, that would be secretory diarrhea in this case. So the consistency of the stool would be rice water stool, just like in a case of cholera. Therefore, the description in the MCQ will most of the time give a hint to you by saying the word pancreatic cholera. That is just to highlight that this is a pancreatic tumor and it is contributing to stool consistency, which would be identical to that you see in a routine case of cholera. And because this is secretory diarrhea, therefore the osmolar gap in this particular case will be usually less than 50. I'll tell you the formula for osmolar gap also on the subsequent slide. But how is secretory diarrhea asked in MCQs? Either he will say diarrhea which is non-responsive to fasting, because osmotic diarrhea anyway will respond to fasting, but secretory diarrhea is non-responsive to fasting. Or he will talk about stool osmolar gap, formula coming up on the next slide. I'll just give the mathematical value here because the stool is going to be rich in electrolytes, as a result of which the osmolar gap will usually be less than 50, whereas in osmotic diarrhea it is usually more than 100. Let's look at other features that can be seen. Because there is diarrhea, there will be hypokalemia component that can explain the muscle cramps of these patients. So that's the first time in a neuroendocrine tumor we are reading about the electrolyte imbalance. I also told you because this tumor can cause release of VIP, which has an action of vasodilation. So flushing episodes can also be given, which can obviously cause you to think in terms of carcinoid tumor as well. But in carcinoid tumor, you would be having asthma-like illness. You will read about extensive pruritus in a patient, cardiovascular involvement in the form of tricuspid insufficiency, pulmonary stenosis. But this is definitely not going to talk about these. It will rather talk about achlorhydria present in these patients, and then hyperglycemia and even elevated calcium. Point number 5 is rare but is important from the exam perspective that hyperglycemia can be seen with VIPoma and hypercalcemia as well, because they like to ask couple of minimal, or I would say minor aspects also. An alternative name for this condition will be WDHA. WD would be standing for watery diarrhea, and the remaining two features I have already marked before you. One would be H would be standing for the hypokalemia component of this patient, and A would be standing for achlorhydria. So these are a couple of minimal aspects which are to be remembered for VIPoma. Then, since I mentioned regarding secretory diarrhea, I will be on this particular slide mentioning two things. One is the formula for osmolar gap, and second would be important causes of secretory diarrhea, which are asked in the exam. In fact, first we can draw a list of important causes for secretory diarrhea. So because they're manifold and these are fact-based questions, so I'll just mention a mnemonic by which you should be able to remember them. That would be DMCL. By DMCL, the first would be diabetic diarrhea. Yes, guys. When you read about diabetes mellitus, the first thing is we always read about osmotic diuresis, but diabetic diarrhea, the autonomic neuropathy component associated, that would be a secretory diarrhea present in the patient. Alphabet M is highly important from the exam perspective. Medullary carcinoma thyroid. It's grossly neglected, but asks medullary carcinoma thyroid, which is having that amyloid deposition, ACAL deposition. This is associated with presence of diarrhea, and that's a secretory diarrhea. That's a minor aspect, but is to be remembered. Then would be alphabet M to remember for mastocytosis. Alphabet C in this case would be standing for carcinoid tumor, which is discussed separately. Even cholera would contribute to secretory diarrhea. Yes, guys, cholera caused by Vibrio cholerae. And then I've explained to you VIPoma, which I'm writing here as pancreatic cholerae. So alphabet C has been taken care of. Alphabet L is again asked in the exam, laxative abuse. He will ask you the osmolar gap in the MCQ. Because of the fact that this diarrhea would be rich in electrolytes, the osmolar gap will become relatively lesser. So what I have done is, in the exam there's a huge list given, but I have tried to narrow down into important causes from this mnemonic DMCL as a short form. I'll repeat the important aspects once again. I'm just double underlining them. Medullary carcinoma thyroid, never should be forgotten. Laxative abuse. Remaining facts are also to be remembered, but I have seen remaining causes people are able to remember, but definitely the ones which are marked can be forgotten as well. So I will be describing to you now regarding the formula for stool osmolar gap. So just like you read about anion gap with respect to metabolic acidosis, HAGMA, NAGMA that are discussed in blood gases and also in the electrolyte section. At the moment I'm focusing on a formula here. This would be 290 minus 2 times the value of sodium in the stool. S here means sodium in the stool, and then is Ks, which means potassium in the stool. We are checking for electrolyte in the stool. If you just focus on this formula from mathematical perspective, what you can understand is that in secretory diarrhea, because electrolyte rich stool is produced, the stool will be having more sodium, more potassium. So if this mathematical values are increased, the overall difference will become relatively lesser. Therefore, I had said that if you get a question in which the stool osmolar gap is less than 50, you always have to think in terms of secretory diarrhea. Causes are enumerated above, but if the value is given to be more than 100, then it can be osmotic diarrhea. Once you get the causes right, then I also want to say that for diagnosis of a VIPoma, you can check out the values of VIP. For somatostatinoma, it is somatostatin values which are to be remembered. And for treatment of VIPoma and for treatment of secretory diarrhea, I'm just making a broad statement here. For treatment of secretory diarrhea and for treatment of VIPoma, the diarrhea component, the drug that will be used, in fact, I'll just put that on the corresponding slide. We will be using octreotide. See, that's an inhibitory hormone of the gut. So it will help in mitigation of the symptoms, and we can be using a long-acting format of this also. To end the discussion, I also want to say that in pediatrics also you read the term primitive neuroectodermal tumors. This that I'm writing, I would say that you can just listen to this, no need of noting it down, because the topic is neuroendocrine tumor. But because of the fact that you do read terms like NET written in pediatrics also, so they are talking about primitive neuroectodermal tumor, and one of them that you all have read is neuroblastoma. This can contribute to elevated urinary VMA levels. It can have an intra-abdominal calcification. And then one more term that will be written would be, in fact, just look at the way they can the terminologies can actually cause confusion. It will be written peripheral primitive neuroectodermal tumors, whereas what I described before you was neuroendocrine tumor. So this is short P written two times, PP net. So this is not a I would say typographical mistake in the book, because when I read it at your age first time, double P NAT, I was squinting and I was thinking that okay, it is some mistake in the book. But then I realized he's talking about a totally different aspect. Peripheral primitive neuroectodermal tumors. The two important ones that you always read about is one is medulloblastoma, again in pediatrics, that would be a posterior cranial fossa tumor, and another one that you read is Ewing sarcoma, that is the small blue round cell tumor. So the message is that these terms that I've written is only for the sake of completion, that when you are reading the books, you always will come across PNET written. So it's not always a pancreatic neuroendocrine. That was the primary objective of the discussion, but even you have to take into consideration alternative terminologies like primitive neuroectodermal tumor and peripheral primitive neuroectodermal tumors. So these are the aspects that I would like you to remember for this particular segment on endocrinology. And keep learning, guys. Keep learning new topics on a daily basis. As I say, always keep hammering, and you would definitely get onto the other side. What I mean is you will come out with flying colors, and you'll be able to get very good ranks. And I've always seen all hardworking people always move on to the other side. I've never seen anybody unemployed. At least doctors, transitory phase, you might feel that you're not getting a job and everything is against you. But then if you keep on focusing, if you keep on working, you definitely are able to secure a very good career. This happens with every professional. It's not only that we doctors suffer from this. Every professional, every guy who's learning a skill will have a phase where he will have a self-doubt, where he will not get employment. He will think that I'm useless, I wasted all these years. But all this time of listening to videos will pay you back. I mean, this is going to give you wisdom, this is going to give you knowledge, and knowledge is power. Thank you so much for hearing me out.